Cool. Welcome, everyone, to another episode of We're All Patients podcast. Today, I'm lucky to have three great gentlemen with me, Dr. Danilo Sirias, Dr. David Boger, and Dr. Benjamin Newman. As a reminder, the TOC Healthcare Conference is on June 3rd. The discount code, I'm going to give an exclusive discount code for watchers of this podcast sometime during this episode, so watch out for that. And let's just jump through the intros. My first guest, Dr. Danilo Sirias, is a professor, systems thinker, and renowned expert in applying the theory of constraints to healthcare. With a PhD in business administration and a background in industrial and systems engineering, Danilo has helped transform patient flow in hospitals and clinics across the country. He's the co-author of a great book called Smash the Bottleneck, and was named TOC-ICO's Practitioner of the Year in 2019. Whether it's the hospital or the chessboard, he's all about strategy and results.
Thank you,
Benjamin. My pleasure. Dr. Benjamin Newman is an emergency physician and managing partner at Healthcare Constraints Management, a seasoned leader in hospital operations with a master's in medical management. Ben brings a pragmatic, results-driven approach to improving healthcare delivery.
Thank you.
With years of experience, with years of executive experience and a deep belief in the power of strong relationships, he's reshaping patient care one constraint at a time. And last but not least, Dr. David Boger is an emergency medicine physician and the site medical director at a high acuity hospital in Virginia. With experience leading trauma, stroke, and PCI care teams, David understands the realities of frontline medicine. He brings both clinical insight and strategic leadership to the conversation around patient flow, efficiency, and emergency care innovation. Gentlemen, thank you so much for being here today. So let's just get right to it. First question would go to Dr. Newman. I really love your passion for transforming healthcare quality, experience, and throughput. Your noble aim is to increase the amount of patients emergency doctors see. Why do you want doctors to burn out?
Why do I want doctors to burn out? I don't want doctors to burn out. It's actually the exact opposite of wanting doctors to burn out. So I think that there is a misconception. To speak directly to your question, there's a misconception that doctors are burnt out because we're working hard, we're working too hard. We have, and we just don't like to work that hard, I guess is maybe the misconception. I think that there's a ton of evidence to suggest that that is not true, that doctors do not mind working hard. I think that doctors feel burnt out because we can't accomplish our goals. We can't do the things that we want to do. We can't take care of patients the way we want to. We see all this terrible stuff happening to patients because they can't get into the system. They can't get into their doctors. They can't get access. And that creates a lot of dissonance for us. It creates a lot of moral dissonance for us in the sense that, we all went into medicine to help people and to work hard, and we're only doing the working hard part. So what we have in healthcare, my belief, is that we have a throughput problem. It's not the frontline doctors that are an issue. It's not our technology, it's not our training, it's not our intelligence, it's not our work ethic. What we do as doctors and nurses and caregivers at the front line is tremendously valuable. It's the system that gets in the way of us actually accomplishing our goals or being effective. And so I don't want doctors to burn out. I want the system to work better so that our clinicians and our frontline staff feel more effective in what they're doing. And the conversation around theory of constraints is that theory of constraints is the throughput solution that we need to make that happen.
So it sounds like it's not.
You tried to get him, right? But he answered correctly.
I saw the trap there.
I tried.
Yeah, definitely.
Can't get past me.
I came out with a gotcha question, and he
Yeah.
So
I actually think
that was the first one then. Now my guard is up.
Yeah. I actually think that part of the problem is Doctors have just been kind of told, you're an RVU horse, put your head down, plow your RVU field, and let other people think about the strategy and the farming, which is, I think, especially when you see that not being effective, when you see the farming not going very well, is really discouraging to doctors. So I don't want doctors to burn out. I want them to be more effective and feel better about their work.
So it sounds like it's not so much the work that's really the culprit in burnout. It's really just where that work is kind of what that work consists of, and kind of how it's applied. Like if doctors feel like it seems like doctors really want to take care of patients and want to spend all their time doing that. But if the system's not very, let's say, efficient at doing so, that's what makes doctors' lives more difficult, not the work itself necessarily.
Yeah, and I would second that as well. If you look at burnout rates, you see the highest amounts among emergency physicians, who are the safety net for this pretty busted system. And if I think about like my good clinical days and my bad clinical days and what separates them outside of any catastrophe, it's how hard did I have to work against the system? Like how much did I have to push to get the right thing done for somebody? My best days are days that I fly through. I see a bunch of people. It's very gratifying. You can make some good diagnosis and feel good about yourself. But the days that you're dealing with a 4-hour transfer or a very complicated medical problem, you can't get the patient the care they need, are hands down the worst.
Well, I would even add to that and say, in the ER, we see the fallout from the rest of the system. We can't say no. We can't throttle our arrivals. We can't reschedule or send somebody elsewhere. And so we see every fallout from the system that doesn't work very well sometimes. And when patients come to us and we just see all these terrible, quality outcomes and patient outcomes and things, like totally aside from just our work, like that takes a big toll as someone who is kind of part of the system and wants the system to work well, and then seeing the system not actually take care of patients, not do what it's there for. I think that plus just the slog that it is sometimes to get through taking care of a patient contributes to the burnout. So
just to give a little bit of the academic perspective, when you see the literature, and also some of my experience is you see the how our providers are used, you're going to see that around 50% of the time, 55% of the time, they're actually doing clinical work. The rest of the time, they're dealing with some fire or they're doing documentation. And we have doctors that study I always joke around, for 1 million years to become doctor. And they were using their time in a way that they're not the best way to do it. So all of this add to two things, right? To the throughput problem, but also through the burnout problem. And it's a system that does that. It's not, the doctors don't have control over a lot of those things. If you improve the system, then you improve the outcomes. It's as simple as that.
Improve the system and improve the outcomes? That sounds very common sense.
Yes.
Agreed.
So if it's so common sense, why the hell isn't it common practice?
Well, I can give you my perspective. There's behind how every system works, there is some assumptions or paradigms or rules that you follow in terms of how you manage the system. And we have the conversation before. We talked about the two main characteristics you have in the way systems are operated, and there are two major things. And I'm pretty sure that Ben and David can elaborate instead of me giving you the academic view. One is the idea, what we call silo, the idea that you have multiple parts of the system and you improve the system by improving each part separately. That's just a belief how the system should work. And the second issue is focusing primarily on cost reduction. The way you improve the system is, okay, I'm looking all over the place. Where can I cut? Can I cut here? Can I cut there? When you put those two things together, you can see the result of that. And that's just the way it is. I mean, that's how the paradigm that it operates in the system. And I'm pretty sure Ben and David can come up with examples of what I just described, specifically to their experience as a healthcare provider.
Yeah, absolutely. Well, I mean, I think to your point, Sam, I mean, it's people, I think people want to improve the system, like the common sense of if we improve the system, we'll improve outcomes. I think everybody agrees with that. I think that where it breaks down is people don't know how to improve the system. Everybody wants to, everybody knows that the system is causing problems, but they don't have agreement where to focus your attention to actually improve the system. And like Danilo said, it's mostly, things that seem like common sense solutions, like cutting costs, or kind of the misconception that, an improvement anywhere in the system is an improvement to the system as a whole, which is untrue. But it kind of makes common sense, if you will.
Yeah, I think Ben really touched on it in that last bit. It's this idea that if you improve anywhere, that you've improved the system, where theory of constraints practicality is based in bottleneck or constraint management, which means if you have a set of dependent events, like you have an ER, a hospital, and a skilled nursing facility, you need to focus your improvement on your constraint. That's the only thing that's going to limit your flow through that system. And whenever we have such a large system, we tend to split it up. And then when we split it up, we put people in charge of little parts of the system. And there are parts of the system that should be inefficient. And that should be inefficient, I think, is the toughest part for people, because we measure almost everything in productivity. And that's where that silo productivity comes in. We also have a ton of data, and it's even more easily accessed. So productivity metrics are everywhere. And every time you take parts of the system and you start tying them to productivity and you lose their protective capacity, then you kind of end up where we are now.
Well, before this, I was trying to think of an example that it was simple enough that I could teach my 5-year-old or my 10-year-old kid. And I was thinking, if you see you as a system, right? And then you have resources, and you have a car in your garage, and then you assign a person, you are in charge of transportation in your family, right? And then you look at your car and you say, the car is most of the time idle, right? There's a lot of waste in that car. And then you're responsible for transportation say, okay, maybe we should share between 4 or 5 families the car. And then I'm a hero, right? I went from 20% or 10% utilization of the car to 80% utilization. You think, what's going to happen. Everything's going to get chaotic. Somebody needs the car and somebody else has it. Imagine that you multiply that and you have responsible for your clothing, okay? A responsible for your refrigerator. And everybody start improving their little part of your life. I mean, that's exactly, I don't know if it's a good analogy. I just was thinking about this morning. Exactly, that's what happened. You divided this part of the whole system into portions, and each person is trying to optimize. And suddenly my life becomes chaotic, and I cannot provide the service that I need because everything is optimized theoretically.
And I think just to play on that car example, because I think that's a really great example, Danilo, is the car is going to be used whenever you need it. Correct. And that's what we've done, just top to bottom throughout the whole thing.
Ben, I know you want to say something.
Oh no! Well, there's so many things I want to say. I have so many things to say. I think that's a great example. You have to have protective capacity. You have to have, unless you want to be everything to circle around that one thing, you have to build in some excess capacity into it. When we were talking recently, another example that I think demonstrates the idea of kind of how the system is actually determined by one thing is the idea of doing laundry. If you have your dryer is your bottleneck. You can only do as much laundry as your dryer is capable of doing. But if you put somebody else in charge of the washer and somebody else is in charge of the dryer, and then you're measuring them independently, the person who's in charge of the washer is just going to keep washing clothes, even if like wet clothes are piling up in front of the dryer. Obviously, that doesn't happen because that system is so closely aligned, but that's what we do. I mean, it's the same thing. We have something that determines our capacity, and then we just kind of make everything else try to operate as good as it can. But then we have, all the consequences of overproducing things, like, wet clothes on the floor is worse than not ever doing clothes at all in the washing machine. And then what we do is we say, well, maybe this isn't working, so let's just cut the washing machine. Let's get rid of half the washing machine or something, or cut its hours by half or something. And then, but then you make the dryer starve for work, and the whole system gets worse. It is, you have to see things as some things have to just have extra capacity to make your system function better. And it's not common sense, because when you start looking to save costs, that's where you look at the things that have extra capacity. But just the variability of the way work happens is you have to have some extra capacity. Especially if you look at like averages. We had this conversation when we were looking at our ER build, and I forget what the resource was that we were trying to staff, but in the ER we have big fluctuations in patient volumes between like day and night, and whatever the conversation was somebody had proposed, like, hey, maybe like let's build, I don't want to say bathrooms or something to averages, and we're like, man, that's not going to work, because we have to build to like our peaks, not our troughs or even our averages. Like if you imagine like a football stadium, if you ask on average how many like bathrooms does a football stadium need, it's not that many, because it's empty 6 days a week or whatever. But at its peak, when everyone's in the stadium, like that's what you actually need to plan for is optimal functioning. And we consistently in healthcare, and probably a lot of businesses, just constantly go towards the mean or the median or even the trough, instead of thinking for, peak functioning and peak busyness and the fluctuations that just naturally come in work and business and that kind of stuff.
Did we bash enough the current systems?
I think we're getting there. So, it's all. So there's a lot to what you said. It reminds me of a phrase I heard a surgeon say once, and kind of against common logic, and that was, don't just do something, stand there. And in terms of, don't jump to conclusions. Like if you see someone, let's say, on their break and they're not working 100%, they're not utilized 100% of the time, it's almost like give benefit of doubt first to, okay, there's a reason for that. And then kind of be able to think about it first before making a judgment about, hey, whether it's good or bad, or, efficient or inefficient. It's kind of, okay, how does this piece kind of fall into the whole system, and how is the overall system doing? What, is this break necessary? Is it not necessary? Is this contributing to the overall throughput or health of the system?
Yeah, I mean, I feel like I've done all the talking, but I think that as leaders, I mean, that's part of our job, is to see the big picture, and ask why, and ask meaningful questions about things like why somebody might be taking a break or not be fully utilized, and then recognize that sometimes that is the absolute best thing that the system can have, is somebody who has time to take a break. Not everyone who is just working to their maximum efficiency. I think that's again, it's not common sense, and it doesn't make a lot of sense especially if you have leaders above you that are, really scrutinizing your, I guess your effectiveness or whatever. It's an easy target to target that stuff. But I think that a good leader asks exactly those questions that you just asked, and interprets them in the context of the bigger goal of the whole system.
Yeah, that's what I was going to touch base on too. It all goes back to your goal. And I think that um, every healthcare system has goals and pillars and has a lot of things. And I think as a provider, my goal is to, take care of people and do so the best as possible and very, as quickly and expedited as possible, especially in the ER. And if that's your goal, it changes your mindset to allow idle time to exist. But healthcare is a tough industry in that there are losses and financial losses, and those variations are difficult to predict and control. And when you start losing money, or if you do lose money, you end up in kind of this idea of idle time's bad. We should be eliminating these hours or these positions, and that usually results in you having less protective capacity and then seeing less people and then making less money. It's called the cost trap, and it's essentially like the cost accounting mindset that just flushes you down the toilet in terms of everything just seems to get worse. Because anytime you make a cut, you're not really sure to 100% what you're cutting, if that's going to end up being actual excess or if that's idle time that the system depends on for protective capacity. So if you have a bunch of transporters in your hospital and you want them transporting patients and your goal is to get patients moved as quickly as possible, you're going to have excess transporters. You don't want them being 100% productive, because then if they are, when you call for one, it's going to take a really long time for them to come get your patient and move them. So I think that there are some healthcare systems that are very quality driven. And when you're very quality driven, a lot of these things become more allowable. So you can say, our budget for transporters is a lot higher this month. And you can say, yeah, but it needed to be because our patients need to be moved, and we're a patient care facility. It's always easier to say when you're making money than when you're like losing money or you have very thin margins. And a lot of healthcare runs on very thin margins.
I would add too to that concept of protective capacity of having to build in downtime, which is not honestly unique to theory of constraints. I mean, that's a core concept of queuing theory and other things, although it is one of the core concepts of theory of constraints as well. That concept of protective capacity is even more important the more like statistical variance and fluctuations you have in your system. So, the less predictable, I guess, work and things are, the more you have to have capacity that can absorb, that creates a buffer for that stuff, or else it reaches your bottleneck. It reaches the thing that determines the function of your system, which is your bottleneck. And, if a variation, a trough or a peak reaches your bottleneck and starves your bottleneck, that's the equivalent of your system being totally down for the amount of time that your bottleneck is down. And so the more variation you have in the system, the more kind of capacity and buffers you have to protect against those fluctuations. And healthcare is, I guess I don't know this with certainty. I've got to imagine it's one of the highest variance industries in the world. People recover at different periods of time. They show up with odd arrivals. There's a lot of human behaviors that drive things in healthcare that are sometimes unpredictable. And, I have to imagine that we have more fluctuations in our field than probably most other industries have, which means, in my mind, we have to be really intentional about our buffers and our protective capacity and, the way that we think about efficiencies, because we could really hurt ourselves if we're not.
Well, I mean, since I started the one bashing the system in terms of the paradigms behind the system, which I mentioned before, the silo mentality and the cost reduction, I just want to go into what are we proposing within the TUC paradigm. Okay, and here's more like a synchronization mentality, where patient-driven synchronization in a way that you can move patients through the system in an easy way, and instead of a cost reduction, we're talking about throughput increases, and so that's the paradigm that TUC suggests, and basically it's based on the assumption that there is an activity within the system that is what determines the output of the whole thing, and also produces value for the system as a whole. And in healthcare, it is, it's a health system, is the interaction between the doctor and the patient. And I mentioned before that what I've seen so far in the literature and in practice, this tends to be around 50%. All right, that's how the system is designed. So if you can create an environment where you support that interaction in a way that moves from 50%, let's say, to 75%, you have an improvement of basically 50%. And it's not unusual in a TOC implementation to see an improvement of that magnitude, 25, 30%, 40, 50% improvement, because now you are looking at optimizing that activity. And all the discussion we're having around the extra capacity, because of the variation, you need the extra capacity to support that activity continue. And again, I'm giving you the academic explanation, and of course in the conference that we're having in a couple of weeks, you're going to see how is that happening in practice. Okay?
I think one of the other huge benefits to theory of constraints in terms of just being in healthcare, and especially in administration, there's probably like 1,000 projects going on at the hospital at any given time. And everyone's like in a rowboat rowing different directions because of that kind of local optimization idea. But when you start to get the theory of constraints, and like Danilo was saying, when you realize that there's only a few constraints that are really constraining your system's flow, you can figure them out. They're not very difficult to figure out. You can just ask the people working and they can tell you pretty much. There's also other tools like current reality trees and negative branch reservations and things that you can learn in theory of constraints that'll help you kind of avoid problems or creating new problems, as well as finding your bottlenecks. But once you understand theory of constraints and you get your team on board, you understand what your bottleneck is, everyone can focus. So it takes that 1,000 projects, everyone rowing in different directions, and turns it into 3 or 4 projects that you can do as a healthcare system or as an emergency department. And then just that amount of administration focus helps you move things forward and see a lot more patients or move through your area a lot quicker.
You can speak, man.
I don't have anything to add. That's well said, both of you.
So, Dave, you said a lot. I mean, that's good information, and I'm just curious. So, for these projects to be effective, because I mean, granted, there's always improvement projects. There's like 1,000 projects, like you said, going on at one time. So would it be impossible to get leadership to prioritize this over some other ones basically, how do you make this a successful project, or how do you get leadership interested in doing it?
Man, it's actually very fascinating problem, because if you talk to any administrator, just go into a hospital and ask them, why they can't get a project done. And it's because they have too many projects and too many meetings and not enough time. So they've actually become a constraint themselves. And, I think the thing about theory of constraints is that it's actually a fact of life. It's not like a throughput philosophy. Like we learned about rate limiting step in chemistry, enzymatic equations, like making dinner has a rate limiting step. Your administration has a rate limiting step in their projects. And, they probably point to IT or point to, some other group. They know when a project goes through that constraint, it's going to then take forever. This is the same thing that the frontline providers are doing as well. It forces you to multitask. You end up starting more projects. You don't finish anything. You have like this explosion of work in process. You're trying to cram everything you can because you want to be as efficient as you can, and use your time as wisely as possible. It's like the same theory of constraints mentality that applies to emergency departments, that applies to how we take care of patients, actually applies to administration. If you're interested, there's a critical chain that helps solve like the project environment world. And you can actually think of patients somewhat like a project in terms of their treatment and disposition. So the core thinking is the same through it all. But I think that what ends up happening is we let so much work in process happen that that it bogs us down to where we really can't get focused. And whenever you have so much things going on, you get more emails, you end up firefighting, just like your frontline providers are firefighting to kind of fix these systematic problems. So this line of thinking goes through everything.
Well, since I want to mention one of the presentations that I want to have in the conference related to project. It's a very fascinating presentation. It is, and this is a project management presentation. And it's related to healthcare because it was implementation of an EMR system. And I don't remember all the details, but I believe that according to the vendor, it was going to take a year or year and a half to do that implementation, to complete the implementation, and then using the TOC tool, called Critical Chain, it was done in 91 days. And that is one of the presentations that we're going to have in the conference. I will give you more details because we want you to attend the presentation. But it is just one example. Like David was saying, it's physics, right? Bottlenecks exist. It's just the way it is. Eh? If it is in traffic, if it is going into the airport, or if it's moving patients through the hospital, it's just a matter of identifying what is the constraint at that point and what do you do to alleviate and improve. I mean, it's just physics. It's just not in the way systems are managed now, and that's what we're trying to do with this knowledge and with this conference to provide an alternative view of how to manage systems.
I'll add, I don't know that I can answer your question, Sam, but I'll kind of add to it to say that I think that executive leadership adds a lot of value when they get behind something like this. I mean, like we already talked about in terms of our problems, I don't want to be too negative in terms of just the problems, but there's a common sense way to handle things. And it takes a little bit of insight and courage to tell the people that you're leading, it's okay for you to have extra capacity. It's okay for whatever. We're all going to focus on this one thing. We're all going to focus on making our whatever we think our bottleneck is, whatever our constraint is. And I'm okay with you spending some of your time to make that other department function better. And it is a hard nut to crack, honestly, because it's not very common sense and it's not really something that happens naturally. You really have to kind of be intentional about learning about it and thinking that way. But I have kind of come to believe that the higher the level of leadership that you can get on board with it, the more likely you are to be successful. Otherwise, you end up doing things that are just kind of in your own department, and you may make your area of control a little bit better, but you still may not be fixing whatever the bigger issue is that makes the system function better. And almost always the real solution is better throughput through the entire system, which will make your department, like whatever you're doing to fix your department, even using theory of constraints, would probably be improved if the entire system functioned better. And that really takes the highest level of leadership to make that happen. So I don't know that I have a good answer for exactly how you do that. I think there's a whole bunch of people that are good at change management and that kind of stuff that they might have better answers than me. But if I would say that you hit on something that's very important for success.
So it sounds like this is kind of a little bit more of an abstract question than, like, if you're making dinner or if you have a car, if we're talking about those things, or doing laundry, it's right there in front of you, right? So like you can tell, okay, like you can time it and you can say, hey, like I tried it one way, it took me 3 hours. I tried it this other way, it took me an hour and a half, right? And then, if I'm making steak and peas, if I make the peas first, then the peas get cold, and that's not really helpful. If I try different ways to kind of optimize the system, and okay, so the steak, cooking the steaks, the bottleneck, how do I kind of organize things around that? When we're dealing with hospitals, it's not as straightforward, right? I mean, it's not, you don't have the dinner right in front of you there. You don't just pull it out from the freezer and like, okay, I'm going to make dinner now. And you have to make these changes while you're flying at 35,000 feet.
Yeah, and I think so. In to get a little bit into the details of theory of constraints, I mean, what you're talking about is so in theory of constraints, there's once you kind of believe the idea of the bottleneck, there's what's called 5 focusing steps, or a cycle of continuous improvement, which is step 1 is to find your bottleneck. Step 2 is to exploit it or to optimize it. Step 3 is to subordinate everything else to it. Step 4 is to elevate it or add capacity to it. And then step 5 is to start over. And what you're talking about is the find, the very first step, which is not as easy always as you might think it is. It might, when you're talking about laundry or dinner, I mean, you have purview over the entire thing, and it's pretty easy to see what you need to synchronize your work to. I think that's why it doesn't happen, is because in complex systems, it's not so obvious. It's not so clear exactly what is causing your system to function the way that it is. There's a lot of tools you can use. I mean, one of the easiest things, honestly, is just asking your frontline staff, like, if you had more of this thing, or what would you need more of for your area to function better? What would you need more of for the hospital to function better? And most frontline people have a pretty good idea of what is in their way. And that's a pretty good place to start, honestly. There's other things that you can do. You can look at your utilization of different areas. The thing that has the highest utilization is likely your bottleneck. And then you can ask yourself questions like, does it need to be leaned down to whatever it is? Can we, many times we've done that to ourselves, and we can easily just add capacity to whatever is our current bottleneck. And then there's some tools, like Dave mentioned, a current reality tree, which is basically a process of just going back and asking why, coming up with a couple things you don't like about your system, a couple bad kind of outcomes that you don't like long wait times, long, whatever it is, long queues for appointments, and asking why, and then just continue to ask why, until you get down to, an answer that kind of explains it all. And then that is also a pretty good place to start. There's lots of tools, and in people who know their workspace, intuition is a pretty good one as well, just in terms of what it might be.
Yeah, essentially just looking at the weights, like whatever queue builds up in front of something is pretty much telling you what your bottleneck is or not. I liked Ben's talk about the current reality tree, but one of the benefits, and like healthcare is very complex. But that actually makes it a little easier in the theory of constraints mindset to make a correction, and that seems counterintuitive. But if you take a simple system, I think a lot like a physician. So if someone comes in and tells me, "Hey doc, I have a fever," and then you have to make a diagnosis. So what's your diagnosis for that? I mean, the diagnosis is very complicated. There's a ton of things that can cause that. That's a simple system. I have 2 inputs. I have a patient with a fever. Now, what doctors actually do in terms of like physical exam and differential, and we complicate the system. We ask them, well, when did your fever start? Are you coughing up anything? And then you get more complication to the picture. So the patient tells you, I have a fever, it burns when I pee, I get a lot of urinary tract infections, and they complicate the system. There's more inputs there. But now it actually is easier for me to solve that problem. Whenever you build a current reality tree, what you see is you kind of take the big problems of your system and you ask why, and you drill these all down. Whenever you get towards the bottom, there ends up to be a couple things that really stand out that cause a lot of system dysfunction. And one of the benefits of theory of constraints is once you do that with a team, everyone's now focused and they see it. So it's like on paper, it's objective. You look at that problem, you solve that problem, and then everything above it gets better or goes away. So with one project or with a small amount of time, you can fix a lot of dysfunction. It takes a little bit of know-how and some time to whittle that out and tease that out. But once you do, the complexity actually works better for theory of constraints than like a simple system would.
So that's cool. So with that in mind, I know we promised our viewers we talk about kind of some of the results that you'll see at the conference. I was wondering if you could shine a light on some of those where they had like just super super results with increased throughput and things like that. Daniel, I think you're on mute.
Yeah. You've seen some of those, right? In the videos.
Yeah. Well, I can talk. So we're still collecting all the results. So I can kind of talk personally about what we're going to be presenting at the conference with some of our results. And I'll kind of start it, and then I'll hand it off to Dave to talk kind of about because what we did just in our own emergency department, and this is one of the things we're going to present. Had so much improvement. We felt so good about what we had done. We actually incorporated that into our plans for a new ER that we're building. So one of the things that I'm going to be presenting on is we had a really significant physician staffing shortage in 2023. Just, a lot of little things. I mean, talking about fluctuations, a lot of little things just came together, attrition, retirements, FMLA, whatever it was, just all happened kind of all at the same time. And we, basically found out we're able to project that we were going to be about 30% short in our staffing. So like one of 3 shifts at our main hospital was going to be empty. was just going to not be able to be staffed. And so we did a lot of things. The 2 big things that we did was we started a process that we called waiting room until results, which was the idea that we put a physician up front at the provider and triage, which is something that ERs use to kind of meet patients when they arrive and they get physician levels orders in. So that's something we had before, but we use that to get physician orders in on patients. And then instead of putting them into beds, as soon as beds were open, we actually kept them in the waiting room to get their results, let their lab results come back. And sometimes patients would go to the CT scanner from the waiting room. Even if we had a bed open, we did that because we knew that our doctors were our bottleneck. We could, even if we filled our beds, even if we filled the laundry machine, we couldn't go any faster than our doctors could actually take care of patients. And the more that we put patients in beds, the more it pulled our doctors away from what they had to do, doing procedures or making dispositions on patients. And so we kind of intentionally throttled our use theory of constraints concepts to intentionally throttle putting patients in beds to maximize the productivity of our bottleneck, our doctors. So the other thing that we did is as we got farther into the staffing shortage is we kind of said, hey, we could probably offload our initial evaluation to a telemedicine provider. And so we started a remote provider and triage program. We hired ER doctors from all over the state of Virginia and let them work from home to basically do provider and triage evaluations on patients over telemedicine. And then we were able to pull our on-site docs back to the back and kind of help optimize our bottleneck, our on-site physicians. So, from the, I mean, we were still short staffed, but our left without being seen rate stayed lower than it had stayed our previous physician shortage. So, staffing kind of goes up and down. And so our previous physician shortage, our left without being seen rate went up to like 10%. And it was less severe than this one. And we didn't go over 8% on this one. I mean, it's still really high, but we were able to mitigate kind of how high it got. And our doc to disposition times, the time that it took our docs to see a patient and then disposition them, discharge them or admit them, it went from 150 minutes down to 90 minutes over the course of putting these in. So, there's a lot less multitasking, juggling a lot less patients at once, being a lot more effective with what you're doing with your time as a doctor. And our productivity actually stayed at what we had budgeted. So, we predict and budget our RVU production, for the year before we knew about the staffing shortage coming. And we were able to basically maintain our baseline RVU production. So, by implementing theory of constraints concepts and kind of synchronizing our work around what we knew our bottleneck was around our physicians, maybe we didn't perform spectacularly, but I genuinely believe we were able to mitigate our, how bad it could have been. And then the waiting room until results process, holding patients, throttling them before we put them in a bed. I don't know, Dave, if you want to talk about that and just kind of give a preview on the build component.
Yeah, at the same time, we were learning theory of constraints and really getting into it and doing our own trees and trying to figure out what our bottlenecks were and how to fix them. We were presented with the ability to build a new emergency department. So one of the things that we really latched onto is, what if we built these theory of constraints concepts directly into like the brick and mortar of the flow of the ED? Meaning that if Ben and I were to go away, the ED would still have to operate like this and keep the physicians as kind of like the constraint. There's workarounds, but when we looked at this ready for bed process that we currently do, and we still do the physician and triage and ready for bed process today, we're essentially doing a quality check before the physician and before the bed to make sure that everything's ready and they can turn that bed over quicker. But what we lacked is the ability to reassess people in the waiting room, and we lack the ability to give them like proper care and comfort. So like medications wise, treatment wise. We've done a little bit more with treatment, but not a ton. But what we ended up doing is developing a new area in the emergency department build plans that we're calling the care initiation area, which essentially means you walk in through the ED, and instead of one big waiting room, which you see at a lot of, actually you see it like all ERs, it's really like a pre-triage waiting room. We've split our wait into internal waiting rooms, and then we built in like this buffer space, which essentially is you get seen by the doctor, they put in your orders, they put in your medications, then you go to this space called the care initiation area, which is a very much focused around comfort. And it's in a recliner chair, and essentially you get your meds, you get your lab work, you get your CT scan, and you only go back to a bed in front of a physician when you're ready for that physician. So we're treating our physicians as bottlenecks because we realize that the ER can only move as fast as your doctors are moving, like Ben mentioned. Slamming a bunch of patients in front of them doesn't get them seen any faster. It actually slows the entire system down because it forces multitasking. And when there's a lot of people to be seen, ER docs like to just pick up a lot of people. But I know that the more people I have, the more multitasking I do, the less patients I actually see. So we've built this mechanism into the ED that allows us to kind of pull patients back at the rate that they're being dispositioned. The other huge benefit is that we actually have beds. Prior to this, we would have a lot of sick people in the waiting room, and that's a really dangerous combination. But when you have bed availability, you're able to pull the sick patients back directly to beds when they need it or when they come in through EMS, and allow those docs to kind of work on that. So the entire ED is set up with buffers. So imaging's got a buffer. The physicians have a buffer. The back door's got a buffer. So we just looked at all the constraints that we came up against, and we buffered all of them, and we used the drum buffer rope kind of idea just to keep flow moving at a constant pace. Because the worst thing that happens, and it happens all the time still, is that you have all of your physicians ready to see patients, but there's no beds to see them in and no patients to see. So essentially for that amount of time, your productivity of your system drops to zero. Nothing's getting through. We call it
with a full waiting room. Right. So
yeah,
there's patients to see. You can't get to them because they're in the waiting room.
Exactly. And to answer a bit of the question too, in terms of the conference, there's lots of good study or lots of good presentations, but there's been a very good systematic review that was done of 42 implementations of theory of constraints in healthcare. And some of the highlights there is they saw a 50% reduction in patient wait times, near 40% reduction in inpatient length of stay. They dropped staff overtime by 93%, boosted surgical procedures by 43%, and decreased like their appointments and no-shows by the 70%. So the data's out there. You just have to know to search for theory of constraints and kind of look at these implementations and then figure out what would work best for you and kind of apply it there. But yeah, you see these because it's a complex system and changing one problem fixes a lot of things. You don't see like single digit percentage increases in things. You see 20s, 30s, 50s, 100%. That's a pretty normal outcome.
That's the amazing part to me, really, is the fact that when we're talking about these numbers, it's okay. So it seems like there's really not much upfront risk for organizations to try this. Like there's no like, here you have to give us $1 million to do this. It's like the people inside the organization can even basically kind of collaborate to do it, and it's really just a mindset, right? So where you just change your mindset to, hey, the status quo is not as good as it could be. And are we happy with the numbers as they are now? Are we happy with sick patients being in the waiting room, potentially getting other patients sick, or just or not being seen fast enough where we can make a difference, before they get worse? And are we utilizing our resources well? I mean, if there's it's kind of like a plane. If you have there's a flight scheduled, and you have the patient, if you have all the passengers sitting in the waiting area, and the flight time, or let's say it's supposed to take off at 1 o'clock, and 1 o'clock comes, 2 o'clock comes, 3 o'clock comes, and no one's moving. It's like, what's going on? Well, our pilots are too busy with eating lunch or taking care of other planes or whatever it is, right? It's kind of like that wouldn't be acceptable in the plane environment. How's that kind of, we've gotten so used to that being kind of acceptable in the medical environment, but it doesn't have to be that way, and it really doesn't take much resources to really start. It seems like what you're saying is the main thing it takes is just a change in mindset.
I mean, that's exactly. I mean, you got it right in that sense. Your mentality goes from, oh, I got this, and this resource. How do I improve this? 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 You move from there to, okay, where's my main bottleneck, right? And then once you have that, you focus all your efforts as a team. You fix it, and then you move to the next thing, and then you fix it. We had this conversation before, right? That once you learn this, it's your frame of mind completely changes, and you start seeing bottlenecks everywhere. We have a previous meeting to prepare for this, and we were talking, in an airport, like the example of the laundry and the way you do dishes and how you drive, and et cetera, et cetera. You just start seeing things differently. This is what makes it easier when you go that way, because you change, like you say, Sam, it's just your frame of mind.
Yeah, I would agree. You can't enjoy an amusement park anymore after you get into theory of constraints. I think that you're right. I mean, I think the investment, it's not a huge capital investment. The investment is in time with your team to both learn it, and then to understand, to kind of understand your setting. So you got to learn the concepts of theory of constraints, and they're very intuitive once you start to learn them. And then you have to take some time to think about your system specifically, whether it's through, a current reality tree, or just, flow mapping, or trying to identify, your bottleneck, and then coming up with creative solutions to make your bottleneck function better. One of the great things about theory of constraints is that it's not a compromise type of solution. It's a win-win solution. The solutions you come up with usually don't require anybody to sacrifice something, whether that's money or time or whatever it is. It's not that someone has to give for you to take. It's everybody wins because the entire system is functioning better. But you do have to invest. You have to invest the time to change your mindset, and then to understand your system so that you know where to apply it. But I think that's really the only investment, and then you might burn, some political capital or something, saying, listen, I know that you want me to be leaner in these ways, but we need to have some excess capacity so that the system functions better. So those are the costs in my mind. Usually there's not much else, at least to get started.
So it's almost like you want to be, let's say if you're walking past someone who's not doing anything, like they're just kind of leaning on the wall and just kind of just taking a breather, instead of being like, it's kind of like also a mindset in that being, or mindset change in that being, going from, why is that guy I'm working so hard. Why is that guy not working? Like I can't carry this whole department by myself. To, hey, that's great to see that the system is working so well that we're able to have excess capacity, because that's where we want to be.
Yeah, I think so. I mean, one of the things that I personally believe also is, I think people really want to do a good job at what they do. Like I mean, there certainly are people that don't care. Although I think those are way fewer and far between than we give credit for. I think that most people, even if they are not, a great citizen of their company, like they want to go to work, they want to do a good job, they want to feel productive, they want to feel like they had expertise and mastery over whatever they were doing. And they want to be a good team member. And I think that, as we feel, tired and burnt out and like the system isn't working, it becomes so easy to assume kind of ill will of other people. But I think you're exactly right. I think we should walk into those scenarios and take a bigger, assume goodwill and take a bigger kind of picture view of the workplace and everything. And I think that it'll pay off a lot in terms of improving things.
I'm going to take a quick break here to just say, to mention the discount code for the conference coming up. So the link for the conference is on the event page for this podcast, and the 10% discount code is my last name, Kozin, followed by the number 10. So KHOZIN 10. Danilo, is that correct? Okay. So
sorry, I think it's only your last name, KHOZIN.
Perfect. And then the number 10 afterwards, right?
There's no 10 after it.
Oh, there's no, just my last name. I'm sorry. So just ignore that part. So just my last name. Okay. Thank you. So I know we're running out of time. This question might take us over time by a couple minutes. But I wanted to ask, so cost accounting versus throughput accounting has been brought up kind of in passing a couple times. So I was curious, what's the origin story between throughput accounting and cost accounting? Were they twins separated at birth, and then now they're meeting again in the final chapter of the movie to fight over the main character, productivity's fate, as supervillain and superhero? Or what happened there?
That sounds like a great movie. I would watch that, although I'm a nerd.
Well, I mean, the cost accounting, I'm a business professor, okay? So we teach that. We teach that everywhere, and it's taught everywhere. And Eli Goldratt, who is in the book The Goal, was the inventor, the originator of this theory. Very quickly realized that cost accounting is an issue because of all the things we've been discussing here. Remember, this was initially developed in manufacturing, so it's the same thing, right? Everybody has to keep everybody busy. Busy, and then they check inventory and so on. Yes, go ahead.
Do you want to define quickly cost accounting and throughput accounting? I don't know. I mean, those are terms that if you've read The Goal, you know what those means. But do you want to quickly maybe before you keep going, you just want to give a quick this is what this means, because there might be people who don't understand those terms.
Well, I mean, the problem with the cost in general is you have costs that are fixed among the whole organization, and we have to find a way to recover this cost. That's the logic behind it. And then what you do in cost accounting, one of the things you do is I'm going to take portions of all these big costs and I'm going to allocate it to a specific thing. Okay, so if I do a surgery, for example, okay, I'm going to take a portion of that big cost and allocate it as a cost of part of that procedure. And that creates distortion because those fixed costs are fixed; they don't go anywhere. And you have decision making. Like I was working with a surgeon talking about surgery in general, and he would look at all his surgery and he said, "Oh, this surgery cost me too much." When he went through the whole process, and what I'm getting from the insurance is not enough to cover my costs. So I'm going to drop that insurance, and he keeps making those decisions based on that way of making calculations. Okay, so so this is what we teach, right? We have different ways to allocate costs, and I'm going to mention all the names because that exist, and that's basically what you learn, right? So I need to figure out the cost of things, and if things are too expensive, well, maybe I drop them, or I try to reduce that cost. And
so
then,
cost accounting kind of makes you look at how much things are costing you, and basically, if it's too high, how do I lower that cost to make more profit?
correct. So everything is around how to find the cost of things, whatever that is, a procedure. So in throughput accounting, you don't do that. You don't allocate anything. You don't allocate. You basically look at your decision making from the overall perspective. So, for example, if I hire a new, I actually went through this exercise in one of my projects. They were all concerned about, okay, the cost of a visit from a doctor is that much. Okay, and so I don't want to hire somebody else because it's too expensive. So we went through the calculation was, okay, because in throughput accounting, you look at the big picture. You look at your revenues, you look at your variable costs, and you look at the overall operating expense. So we went through the calculation. I said, okay, if you hire a new doctors in this case, what is the revenue that you get? I mean, the demand is there. That's one of the things about healthcare. It's not an issue of demand like in other industries. The demand is there. If not, just look at your waiting list, right? Or you look at your waiting list everywhere. So that's not an issue. It's not an issue of demand. So you can calculate your revenue, and if you have any variable costs, you can subtract that from your calculations, and then you see how much your operating expenses will increase. What happened in theory of constraint, many times you increase your revenues, and your cost stays the same. So all the revenue coming, assuming there is a little variable cost, so you can subtract that. All the revenue coming from that extra procedure goes to your bottom line if you're looking at as a for-profit organization. And it's like a shock, right? When you go, sometimes when I'm working in project, I tell people, what will happen if you can see, you have 10 providers, right? Each one of them can see one extra patient a day. And you make the calculations in terms of revenue. And there's no extra increase. You're not hiring anybody else. You just do what we're discussing here. What is my constraint? How do I optimize that constraint? And you can see one more patient per day for all your providers. And you make the calculations. It's humongous. If you're looking at, I'm putting my business hat at this point, and that's how you make the decision, because somebody may say, oh yeah, of course you can do this by increasing your cost. All right, you put a lot of people and then suddenly everything moves, but that's not how you make the decisions. You look at the whole usage throughput account and you make the calculations, right?
So in throughput accounting, it sounds like the holy grail is increasing throughput without increasing expenses.
Right. And what happened many times, actually your operating expenses may go down because there's a lot of inefficiency that increases your cost. But generically speaking, right, you can increase your throughput by managing your constraint better, keep your operating expenses fixed. And suddenly, if you're looking at from the profit perspective, you can do that. But again, this is a result of seeing more patients. And that's what Benjamin was saying a few minutes ago. It's a win-win. Okay, your doctors are happy because they're seeing patients. That's what they train for. Okay, you're optimizing their time. By seeing more patients, you bring more revenue to your system, and everybody's happy. Right? You see more patients are happy. You generate more revenue. Your C-level people are happy. Your CFO is happy, and your doctors are doing what they are trained for. And that's just a win-win situation. Look at the opposite of what I'm saying. Okay, you're reducing costs. Okay, and then you put in some of those extra activities to your physician, so your physician are unhappy. Are you seeing less patients? At the same time, you're getting more revenue. I mean, you're getting completely in the opposite direction, and this is what happened in healthcare now. And there is a way to improve that with what we are offering in terms of knowledge. Okay. Did I say enough, Sam?
No, I mean, it sounds. I mean, honestly, it sounds. If without, it sounds like you're kind of getting the best of all worlds. I mean, really, you're lowering your inventory or patients who are waiting. You're increasing your profits and you're lowering your costs. I mean, like it's like, why wouldn't someone do this?
Right. Even if you are a not-for-profit and you depend on donations, in one project that I'm working now, we're using those capabilities, new logistic capabilities, to go ask for money. Look, we have improved our system. We can see more patients. We need your help, so we can increase. I mean, so you can still use those principles. If your mission is not to make more money, but you make a case, right? In terms of I have improved my system to the point that I can see more patients, but I need a little bit of, I need help, support our mission so we can grow and get people better. So it still applies. In case somebody in your audience is thinking, well, that applies for business, but if it's a not-for-profit, you can still use your improvement from health from theory of constraint to go request funding. Yeah.
So one last question before we, unless there's other topics you want to cover, but the last question I had for you today was a practical one, really. How can someone watching this make use of what we've talked about at their workplace, like today? Like, was there something small they could do to start the process?
I would say, if you're, I think there are some things you can do. Although there's a little bit of a hurdle, especially in getting, if you want the system to function better, you need people to come along with you. I think from a like, if you are just a worker and from a personal perspective, one of the best things you could do is stop multitasking. For physicians, ER doctors are taught to, that we are supposed to multitask. That's what we learn in residency. And instead of personally working on multiple things at once, focusing on just finishing the things that you can finish before you even start something else, whether you're seeing patients or, working on projects or whatever it is. I think that's the one thing that that you personally could start doing that would improve your own personal productivity and probably the productivity of your workspace as well. That's my thought. You guys might, Dave and Danilo, you guys might have other thoughts. And then the other thing I would probably recommend is start reading about theory of constraints. There are, it's something that has some nuances, and kind of one conclusion leads to another very naturally, but sometimes you kind of have to go all the way through understanding all those, or at least having all those epiphanies before you really start to implement things. And starting with reading the goal would probably be a great, thing. So stop multitasking, read the goal for 30 minutes every night until you're through it. Those would be my piece of advice for someone who wants to get started right now.
I probably would add something. There is a concept in TOC we call full kitting, and it's applicable to anything. I mean, it's the idea of you don't start something until you got all the things. I mean, so you're gonna start cooking, you make sure all ingredients are there. Okay, if you're gonna do the laundry again, you gotta detergent and everything, and it happens in healthcare too, right? If you are a doctor and need some full kit of information or a full kit of tools, do that. So you can do also that personally. In addition to what Ben said about avoiding multitasking, I would add to the personal productivity the idea of the full kitting into the equation.
And one final one, just look across your system and see what has the longest wait. Go to the frontline people in charge of that area and ask them what they need to get that wait to shrink. How do they get more people through their system? And then do that thing.
Well, I mean, that all sounds like very good practical advice. Honestly, it's and it's cool that so really looking at seeing where the biggest weight is, and then kind of asking the people who are on the ground at that place about what could be done to change it.
Right, and if you work in a clinic and you have this way of thinking, like I said before, that's exactly where you start. Okay, you look around. Okay, this is the beginning of the system. This is the end of the system where things are getting stuck, right? Where things are getting stuck, and then okay, is there usually there is an issue, a conflict you have behind, but that's, I don't want to get too technical into this, but you can look at that one thing and then improve, and then suddenly things start flowing, and it gets you going. Now, the ideal situation would be that the leadership was, that's where you get the best impact, right? If you, like, I'm working on a project in a hospital, the whole leadership, the CEO and all this, right? And they were able to make, because they can see the bottleneck at the level of the hospital, all right? And say, okay, this is all the things that happen in the flow of the hospital. This is where the main bottleneck is. They have that big picture, and then we can focus on that part and improve it. And then we know the bottleneck is going to move, the main constraint is going to move to another unit. And then you go to that unit and you zoom in, right? This is the big unit that is the main bottleneck. Then you zoom in, or within that unit, this is a major thing. And then you fix that, and then things start moving. So, I mean, that's, if any of your audience is executive at the level, this is where you have a huge impact. I mean, it's almost immediate. In a matter, we have a saying in TOC: if you don't get results in less than 3 months, big result, you're doing something wrong. It's like we have like that benchmark that in a huge system, in a matter of 90 days, you should see impact. Probably can be done less, but there are obstacles in getting that. But in 90 days, you should be able to see huge improvement.
Thank you, Danilo. That's, I love the huge improvement part of it, because that's explain. I mean, I think that's kind of, there's not many things you can get in life that within a short period of time, with really a small amount of investment, can get you outsized returns fast. So yeah, I mean, that's amazing. Any parting thoughts, as we kind of draw to a close here?
I don't think I have any thoughts. I just want to thank you for having us and giving us the opportunity to, talk about what we're passionate about, and hopefully we'll see people at the conference, and obviously, people can reach out to us as well, through LinkedIn or whatever way that we can get you our contact information, we can do that. And I just appreciate the time and the microphone to be able to talk about something that we really love to talk about.
Yeah, we definitely we can definitely keep talking forever here about this, because it's a huge problem.
Yeah,
I mean, it's a huge problem worldwide. I mean, I don't have to convince probably anybody from the audience that it's a huge problem. And the purpose, and this conference is the first one we're doing. There have been implementations here and there, people doing it in multiple places, but we have enough cases at this point that we decided, I mean, let's do one, because we're going to move beyond just doing our little things in our hospital, right, and improving our hospital. We have a lot of people now, enough people that are interested in moving this beyond their environment, and because it's a huge need out there, and it's a set of ideas that are not new in the world of business, but they are relatively new in the world of healthcare, and when I put it out there,
I think that bears repeating, though, because so this might be new in healthcare, new kind of like a new concept in healthcare, but I mean, it's been proven over and over and over again in business. I mean, including like some of the biggest companies out there, like I think we talked about last time, like Amazon, their fulfillment centers, right, kind of being designed with theory of constraints in mind. So, I mean, and Jeff Bezos credits theory of constraints.
There's a couple of books that, according to the news, that he recommends, and one of them is The Goal to read, because it's common sense. And even if somebody didn't use necessarily TOC, when you see what's behind the actions they are taking, you can trace it back. That they fix the constraint and they improve it. And so what the theory of constraint did was create the methodology, right? Create the principles and the tools so you can apply it. We were having a meeting yesterday, and I was talking about, somebody told me, why you like that? I said, it gives you superpower, right? And they were laughing at me when I was saying this. Because it's a new way. Another example I like to give, and I don't have the technology perfectly. You know, when you do high jump, I always tell that to people. For a long time, people will go in front, right, to jump. And then somebody was crazy enough, oh, I'm going to go in my back, and suddenly the improvement went dramatically that way. And that's what's happening with TUC. It's just new paradigm. It's a new way of thinking. And there's a need, you know, more than any other industry is healthcare. And we had to, you know, take advantage of that this technology, I believe.
Cool. I mean, yeah, it is applying concepts from other fields to healthcare that have been proven and really to help improve things. And like you were saying, you know, here we're dealing with patient lives, and it's no other industry needs it more so than healthcare. Well, thank you guys so much for joining me. This has been awesome. I love talking. I mean, like Danilo said, we can keep talking probably for hours and hours. But thank you so much for our viewers and for joining us. And I hope you'll join us at the conference. And it's virtual, so it's at home in the comfort of your couch or computer chair. And yeah, we can all change healthcare together, and looking forward to it. Thank you guys so much.
Yeah. Thank you very much for having us.
Thanks.
Thank you, Sam.
My pleasure.